08:30. So I hope everyone had a good weekend and you're ready to go with nursing process. For the next 2 days, we're going to learn about critical thinking and nursing process. And this is very important stuff because this is foundational. You're going to use nursing process throughout the rest of the program and throughout your career as a nurse. So I'm going to go ahead and share my screen. Hopefully this will work. Okay. There's the chat. Okay. All right, so we're going to start talking about critical thinking first. Remember to hold your questions till the end. I'm going to stop probably about 10 or 10:15 and then take any questions that you may have regarding the content that we get through. So do we have any specific questions before we get started? You guys ready to go? All right, so critical thinking. What is critical thinking and why is it important to nursing? We normally think in a critical way. So if you can read this document, you can critically think. This is not something that's just confined to nursing, but it does require a certain level of cognitive skill. So you do have to use your brain when you critically think. Now there's a lot of different definitions to critical thinking, but I think the best one is Gordon. So Gordon says that critical thinking uses the mind in forming conclusions, making decisions, drawing inferences, or reflecting. So it's a way that we problem solve. It's a way that we think through issues. And what is critical thinking a combination of? Well, in order to be a good critical thinker, you have to be able to logically think things through. So reason thinking. You also have to be open to alternatives. So you have to be able to think outside of the box, view things in a different way. Ability to reflect is very important too. So being able to self-reflect and look at why you did something, why something occurred the way it did is important to being a critical thinker, and a desire to seek truth. So let's think about a situation that occurs to everybody. So let's say that you've got clinical on Wednesday morning and you go out and start your car and it won't start. Okay, your critical thinking skills immediately come into play. So just in the chat feature, tell me some things that you might do in that situation. Uber. Okay, call an Uber, call AAA, call for help. Jumpstart, go get your husband out of bed, call a friend, very good, call the professor, Emily. You got to let your faculty member know that you might be late. That's good. What about troubleshooting the car? Could you troubleshoot the car first? What are some things you might do? Yeah, you might check the battery, you might jumpstart. How about gasoline? Good, very good, Christy. Check the gasoline. So troubleshooting the car might be something that we do first. And then if we see that there's plenty of gasoline and maybe the battery isn't working, but we don't have any other way to fix the battery, then we might start looking at calling Uber, calling a friend, calling our husband, letting our clinical instructor know that we're not going to be there. So all of those are steps in critically thinking through a situation. So critical thinking skills are cognitive. Again, you have to have a certain level of intellectual ability to be a good critical thinker. So let's say that you're working one night and you go in and take your patient's blood pressure, and the blood pressure is high. So the next thing you're going to do before you run and call the physician at 3 o'clock in the morning and really irritate them, or run and get some medication, is you're going to gather more information. And you're going to objectively gather information. That means you're not going to be personally involved. You're not going to have a lot of emotional input into this, but you're going to step back and be objective. Because remember, being a good critical thinker is wanting to know what's going on, trying to gather as much information as you can. So what are some ways that we can gather more information? What are some sources? Very good. We may want to look at the patient's chart and see what their blood pressure was. Excellent, Nancy. We want to get a manual blood pressure, because remember, we're not treating machines, we're treating patients. We want to further assess. Good, John. So we want to get more information, and that may be going through the chart and reading the chart. That may be sitting down and talking to the patient and listening carefully, reading thoughtfully through the chart, talking to family members. So we're gathering more information. Okay, can you guys hear me now? Good. I think Professor Arnapol muted me. I don't know why. Okay. We also want to validate information, and that is very important. So if we go in and check a patient's blood pressure with the machine and it says that it's 210 over 110, and the patient seems to be fine, they don't seem to be in any distress, they don't have any complaints, then we would want to validate that information. And Nancy, what you said is exactly right. Validating that information would be going and getting a manual cuff and checking to make sure that the equipment is working correctly. And then we want to organize or group our information. So let's say that the patient tells us that they had their tonsils out when they were 6 years old. Is that going to be relevant information to the patient having a high blood pressure right now? Right? No. So the irrelevant information we want to put to the side. Let's say the patient is blonde. The patient is female. The patient's been married twice. So all of that information is not relevant to what we're dealing with right now. Now, if the patient told us that they had surgery yesterday and they haven't had any pain medication in the last 10 hours, and their pain is a level 6 out of 10, would that information be relevant? Yes. So again, we're organizing or grouping relevant information, things that are going to help us to think through this particular situation. Now, critical thinking also involves attitudes or traits, and these traits can be learned. So as a critical thinker, we want to embrace all of the traits that you see on this list. We want to be independent thinkers. So good critical thinkers don't necessarily believe everything they see. Again, we go back to the blood pressure that really may not have been accurate. We're going to validate that information. So, you know, being a nurse and checking that blood pressure and seeing that it's 210 over 100 and then just going and writing that blood pressure down, you know, that's negligent. We're not caring for that patient. We're not being an independent thinker. Having humility, realizing that we don't know everything. That is a big red flag to me when I work with someone that doesn't possess intellectual humility. They cannot grasp the fact that they may not know everything and they may be wrong. So being able to be humble and recognize limitation is also very important. Being fair-minded, not passing judgment on a situation, but making an impartial judgment is very important. And persevering. So when we see something that is abnormal in an assessment, that needs to drive us to get more information, more information, more information until we have all of the information to make a good decision. So why is critical thinking important for nurses? Well, number one, nurses deal with complex situations. Our patient can go down the tubes in a matter of minutes. So you can be talking with the patient and the next minute the patient stops breathing or the patient's unresponsive. And you have to be able to critically think, what am I going to do? What am I going to do to take safe care of this patient? I always used to have this little trick. I used to work night shift on a cardiac floor when I first got out of school. And I would always think, now let me see, what is the worst possible thing that could happen tonight? You know, a patient stopped breathing, a patient's heart stopped, and what am I going to do if that happens? So I would kind of run through these scenarios. We also need critical thinking skills because every patient is different. So the concepts that you're learning now are very important, but there's going to be 1,000 different situations that occur, and you have to be able to critically think through each of those scenarios to get the best outcome for your patient. Now, you guys have already taken your first exam, so you know nursing is an applied discipline. It's not here just memorize a normal blood pressure or memorize a normal heart rate. It's can you take those accurate numbers and apply it to a situation and critically think what needs to be done for this patient. We also use knowledge from other fields. So we are a collaborative discipline. We work with physicians, we work with respiratory, we work with dietary, we work with everyone because we're the ones with the patient 24/7. And so we pull in that information from other disciplines and use it to enhance those critical thinking skills. And nursing is very fast-paced. This is not something where you have a lot of time to process information when you're dealing with an emergent situation. And patients that are in the hospital now are sick. So when I first started in nursing out of school, we had elderly ladies who would check into the hospital for a weekend of R&R, rest and relaxation. We no longer have that. So if patients are in the hospital, they are very sick, and we have to be able to think through those situations quickly. And there are different kinds of knowledge that we use in critical thinking. And this gives us a holistic picture. So there's theoretical knowledge, there's information, there are facts. This is information that you get from lecture. So it's pathophysiology, why things happen the way they do. There's also practical knowledge. So practical knowledge is knowing what to do and how to do it correctly. So these are things that you learn from lab. This is information that you learn from clinical. There's self-knowledge, so self-understanding. So that also involves the ability to reflect. So do we have a personal awareness of our limitations? You know, why did we do something? Because we will make mistakes. Mistakes happen in nursing, but we have to be able to self-reflect on that. And then ethical knowledge. So this is a moral compass. Does a nurse know the difference between what is right and what is wrong? Patients suffer with unethical nurses. I worked home health for 15 years, and I'll never forget orienting a nurse. And we went into, I think this lady was 87 years old, and she had a little candy dish sitting out. And she lived in one of the senior assisted living facilities, so I'm sure her income was limited. And the new nurse sat down and just grabbed herself a handful of the candy. And the patient was talking about, she had a rocking chair she was going to get rid of. And the new nurse told her that she'd be happy to come back and take that rocking chair off her hands. That is wrong. You know, you have to know the difference between what is right and what is wrong. So all of these components are very important to critical thinking in nursing. Now, it would be great if we could just type into the computer criticalthinking.com and get all of our answers, but nursing doesn't work that way. You know, we've got to be able to actually do the thinking. So let's look at this question and see how you guys do with this. So the most correct definition of critical thinking is, you guys look at those answers and then type in what you think. Good. So it's C. It's purposeful, it's analytical thinking that results in a reasoned decision. Do you understand why A, B, and D are incorrect? What's incorrect about A? Very good, Ginger. So the point of critical thinking is not to show other people that they're wrong. What about B? Why is B incorrect? Right. It's critical thinking is not there for us to show why we're right and everyone else is wrong. And then what about D? Why is D incorrect? One correct answer, right? Because again, it's just like I said, you know, there are a lot of different ways to do things. So there are multiple correct answers. Okay, let's look at this one too and see how you guys do with this. So the nurse is preparing to admit a patient from the ED. The patient has chronic lung disease and has used tobacco for 30 plus years. The nurse used to smoke a pack of cigarettes a day and worked very hard to quit smoking. She thinks to herself, I know I tend to disapprove of people who use tobacco, especially when they have a serious lung condition. I figure if I can stop smoking, they should be able to too. I must remember how difficult that is and be very careful not to be judgmental of this patient. This best illustrates what? Very good. Self-knowledge. So this nurse has a bias, right? And she knows she has a bias. Is it okay to have a bias? Yeah, it's okay to have a bias. The problem is if the bias interferes with the care that you're providing the patient. So you have to keep that bias in check, just like what the nurse is talking about. Good. Now I want you guys to read both of these scenarios, and I want you to tell me which one of these nurses is using good critical thinking. Good. So Lily is exhibiting good critical thinking qualities. What is Erin doing that does not show good critical thinking? Right. Just accepts it as is, not finding out a true value, not taking further steps. So if this patient were to get into trouble physically, and let's say they coded and maybe even died, would Erin be liable for that? Yes, she would, because she took the blood pressure, she couldn't hear it, and rather than doing anything about it, she just recorded it as a 0 and left it as is. What is something that Erin could have done? Asked another nurse to check, get a manual, tried another arm, get a Doppler. Right. So there are a lot of things that Erin could have done to check that blood pressure. And if Erin indeed could not get a blood pressure, that patient didn't have a blood pressure, then she may need to call a code, she may need to call a rapid response, call the provider, something like that. So good, guys, y'all are doing well. Okay, so that's critical thinking. But now let's talk about nursing process. And nursing process, again, this is a foundational concept. So you really need to understand this. So a definition of nursing process is it is a systematic problem-solving process that guides all nursing actions. And the purpose of nursing process is to provide patient-centered care, which is the purpose of everything that we do, is to take safe care of our patients. So when we look at nursing process, it involves both thinking and doing. So we have to be able to do both of those things. That's why you have 3 components that make up your first class in nursing school. You have your lecture, lab, and clinical, because you have to be able to think and you also have to be able to physically do. Nursing process is a scientific reasoning that gives us a framework that allows us to put patient information into perspective. So it's a way of thinking through those situations. And the steps involved in nursing process, and you may see 2 different ones, but your textbook uses the acronym on the left, which is ADPI. So you have assessment, diagnosis, planning, implementation, and evaluation. And there are actually 6 steps, and we'll talk about that in just a minute. So we're going to briefly look at each of those steps, and then the remainder of today and tomorrow, we're going to go into great detail with looking at each of these steps in working on a care plan and and identifying care in terms of nursing process. So the first step is assess. So we are gathering data, we're evaluating data, we're evaluating the patient's condition. The second step, D, diagnosis. Diagnosis is nothing more than a patient problem. It's just a patient problem. P is planning, and planning is broken up into 2 steps, and that's where we get the 6. So it's planning goals or patient outcomes, and it's planning interventions or things that we actually will be doing to the patient to help them to get better. I is for implement. So we're actually taking those interventions that we planned and we're doing them. We're implementing them. And then E is evaluate. So we're assessing the goal that we identified for the patient to see if that goal was met, if it was partially met, if it was not met at all. So how is nursing process related to critical thinking? They're 2 separate concepts, but they are definitely interlinked. And if you look at this little diagram, it will show you the ADPI acronym with the star points of critical thinking. And I don't want you to worry about memorizing the critical thinking star points. You do need to know the nursing process acronym though. But nursing is a problem-solving process that uses many individual critical thinking skills. So there are 3 levels of critical thinking. It's theorized that students are at a level 1 when they get out of nursing school. Level 2 is typically achieved after a year of clinical practice, and level 3 is achieved after 5 years of clinical practice. So you can see that by the time you finish our program, you are going to have a lot of information, but you're still going to have a ways to go in terms of developing those critical thinking skills. That's why hospitals will always put a new grad with a preceptor or a mentor. The more years experience, the better the critical thinking skills for most people. All right, so let's look at this and see how you do with this in terms of using the nursing process with the ADPI acronym. So you have an 82-year-old male admitted to the hospital 2 days ago with pneumonia. You go in and introduce yourself and let the patient know you'll be taking care of him today until 3 p.m. You notice a urinal with 30 milliliters of dark tea-colored urine sitting on the overbed table. So let's look at the nursing process and critical thinking and figure out some things that you're going to do. So we have A in the nursing process. A is for assess. So what are some things we're going to assess? And Aaron has already said we're going to assess for dehydration. We're going to assess lung sounds. Very good, Kimberly. We're going to assess what the intake has been for today. We're going to assess lungs. Good. We're going to look at lab results, the amount of output. Excellent. Medication. Good. So we're going to assess a lot of information. What about mobility? Would we need to assess mobility? And if so, why? Very good. Urine is on the table. He may not be able to get up and go to the bathroom. So a risk for falls. Good. So we're assessing Information. Now, our next acronym is D. D is for diagnosing or patient problems. So what do you think some patient problems may be that you could identify? Possibly dehydration. So he's admitted with a medical diagnosis of pneumonia, and that's a medical diagnosis, not a nursing diagnosis. A UTI is a medical diagnosis. So keep it in terms of a human response to a health problem. Good, Heather. Limited mobility. Megan, risk for fall. Taylor, very good. Trouble breathing. You're framing it in terms of a patient problem. Issues with ADLs. Maybe a risk for infection, maybe some renal issues, problems feeding. Very good, Bridget. Good. All right, so you've identified several patient problems. That's good. And what's our next step in ADPI? Planning. So we're going to plan a goal or a patient outcome. What might be a goal or a patient outcome? Improved breathing, Ginger, good. Hydration, good. Consistent fluid intake, yes. Spirometer use. Very good, Bridget, very specific. Mobility. Okay, so we've got some goals. We want the patient to be able to get up and go to the bathroom. We want the patient to take in more fluids. We want to make sure that they're using their incentive spirometer. So those good, very good goals. What's the next piece of planning? We're planning interventions. Remember, we're planning interventions. So we have two phases in planning: planning goals, planning interventions. So what are some interventions that we could do with this patient that you could figure out just off the top of your head? Fluids, spirometer, making sure the patient's using the spirometer, increasing fluids. Oh, good. I like that, Tamara. Keep water pitcher filled. Very good. Mobility evaluation. So whenever you are writing a plan of care for a patient, the first intervention that a nurse always does is assess. The first thing that you do is to assess. On any test question that you ever see, when it asks, the first thing the nurse does, and you have the option to choose assess, it's always assessment. That should always be your first intervention, because without that assessment, you don't have the information that you need. So that's always first on interventions, but those are some good ones. Very good. Now, our I stands for implement. So at that point, we would then do these interventions that you've planned. And then E is for evaluate. When we evaluate, we're evaluating the goal. We're not evaluating the specific interventions. We're evaluating the goal. So did the patient increase their fluid intake? Did the patient get up and go to the bathroom? Did the patient use the call light when they had to go to the bathroom? So we're evaluating the goal. If the goal is not met or is partially met, then we would go in and tweak the interventions. We may need to do something a little bit different, or we may need to go in and tweak the goal or get rid of the goal. So it's a constant evaluation process. Good, you guys did very well with that. Now let's talk about care plans. So what is a nursing care plan? Because you all will be writing a nursing care plan. You'll probably start it this week, and by the end of the semester, you should be able to write a full care plan. A nursing care plan is a written guideline for coordinating nursing care. It's the nursing process in written form. And that's why we're going to work through process by developing a care plan. Hopefully, it will help to jog your memory as you're looking at questions and figuring things out. It promotes continuity of care. So if I come in and pick up Kimberly's care plan, when she's been taking care of a patient on day shift, and I'm going to take care of this patient on night shift, I should be able to pick that care plan up and know exactly what Kimberly has been doing with this patient so that I can follow that plan of care and promote the continuity of care. Now, let me ask you this. Can an LPN initiate a plan of care on a patient legally? That is correct. The answer is no. A CNA cannot legally initiate a care plan on a patient. This is something that a registered nurse has to do. So when we start looking at delegation, initiating a care plan, revising a care plan is not something that a registered nurse can delegate out. Now, what does a care plan consist of? It consists of assessment data that you've gathered. It consists of nursing diagnoses or patient problems. It has goals or patient outcomes. It has specific nursing interventions, and it has evaluation. So again, it has all the components of the nursing process. Now, when we talk about interventions, there's a ton of interventions that you can use on patients. You know, I could have asked my grandmother, so what should I do for a sore throat? My grandmother probably could have given me 5 to 6 interventions off the top of her head. But we are nurses. We're a profession. We work off evidence-based research. So pulling things out of your head when you're writing a care plan is not the best practice. It's not the best thing to do for your patient. That's why you use care planning books. That's why when you develop care plans, you get your textbook out and you look at information, because we're using evidence-based practice. But we can choose from interventions such as ADLs, specifically how we're going to help the patient with their ADLs. Maybe they need to be given a bed bath. Maybe they just need to be assisted with their bath. Multidisciplinary treatment. So medications would go in interventions in your plan of care. If you had to monitor a patient's pulse ox, that would go into your interventions. If we were going to turn a patient every 2 hours, that would go into the interventions. And especially something that's very important that I see students leave off is teaching needs. All patients have teaching needs. So there may be a knowledge deficit regarding a new medication or a new diagnosis. So that would be a wonderful opportunity to teach the patient, write down everything that you're going to teach them. And again, the next shift coming in or the next person coming in can just pick up that plan of care and know exactly what to do to maintain that continuity. So you have to look at a care plan as a map to guide the care. So it ensures that care is complete. It gives us a written document to go back and use as a guide. It also does something else that's very, very important, and it meets the requirements of accrediting agencies. So I'm sure many of you have heard of Joint Commission. Joint Commission is an agency that accredits the bulk of the hospitals in this country and allows them to get reimbursement from Medicare, Medicaid, and various other insurance companies. If hospitals don't meet the requirements of those accrediting agencies and they risk losing their accreditation, they risk losing their funding. So it's all about money. So they will go back and look at care plans and make sure that nurses have completed care plans, they've updated them. They'll make sure that the care plans are accurate. So part of what you're doing in learning how to complete care plans as a student, again, you're training to be a nurse. You're learning how to complete the care plans. Now, there are different types of care plans that you'll see in charts. And I encourage you, as you go into the clinical setting and you have some downtime, to go to the chart and look at the care plan. One type of care plan is known as a critical pathway. A critical pathway is focused on medical interventions and it's tied to reimbursement. So nurses may not necessarily initiate a critical pathway. The physician may do it or the provider may do it, but we definitely need to go back and look at that and make sure that the care is coordinated based on that. A standardized nursing care plan you will find on All Patients chart. So this is a detailed care plan. They're very nice because they're pre-printed, and for the nurses, many times they just have to go in and check things off and update them and individualize them for patients. So you can a lot of times go into the computer, into the data bank for care plans and put in a specific diagnosis for a patient. You can put in a nursing diagnosis and it will come up and you'll see something like this. So you see it's a matter of check boxes. If the patient is having pain, then they should, be exhibiting some of these descriptors, such as a change in blood pressure, self-reporting pain. There are related factors or causes, things that are causing the pain. You may pick one of these goals to go along with your patient, and then a list of interventions. So they're all different, just depending on the facility you're in. And there are also unit standards of care, which can be incorporated into care plans. And these are expected interventions by the nurse for all patients. So an example of that may be a unit requires hourly bed checks by the nurse, where the nurse goes in and checks on the patient every hour, or vital signs, maybe every 8 hours or every shift. So it's just a unit standard of care. And again, you will be responsible for providing a written plan of care for your patients. And starting in Med-Surg 1, every week, you will be doing a full care plan on every patient that you have. So this is not busy work that we're giving you learning how to write care plans. This is helping you to learn how to think like a nurse. Okay, well, let's go ahead and take a 10-minute break. We're about 9:15, and we will start back a little bit before 9:25, and we'll start into nursing process. All right, so let's go ahead and get started back. And we'll go into the first step in the nursing process, which is assessment. Assessment is the systematic gathering of information related to the physician. That could be a physical assessment. It could be an interview to get a health history. It could be assessing socioeconomic status, cultural status. You could be listening, you could be assessing community needs. So it's gathering data. And one thing that you may end up seeing in place of assessment is data. It's the same thing. You're just getting information. Now, you guys had the lecture for assessment with Professor Arnapol. So what skills do you use in assessing? Remember the skills that he taught you? Inspection, good. Palpation, good. That's what I'm looking for. Percussion, auscultation, excellent. And there's one more. Olfactory, very good, Eleni. So what you smell. So it's using all of those skills. You've got this tool belt, an arsenal full of things that you can pull out and use as you're assessing your patient. And remember, that is the first thing that a nurse does, is to assess. So why do we gather that information? Well, we're trying to identify the health problem. What's going on with the patient? What do they need? Do you think that it's important to ask the patient what they think their need is, what they feel like the biggest problem is? Yes. So again, if you see something like that on a question, you know that patients are always involved in the entire nursing process. So you include their information. Now, there are two sources of information. There's a primary source and there's a secondary source. So your primary source is information that you get directly from the patient. Everyone and everything else is considered a secondary source. So interviewing your patient is important. Talking to your patient, establishing those grounds of communication is very important with your patient. You also have to make sure that your patient is a reliable source. So if your patient is a poor historian, if their information is conflicting, they may think it's 1963 and you realize that they may not be the best person to get information from. You can still get some information from them. You know, are you hurting? Are you in pain? Are you thirsty? Do you need to go to the bathroom? But as far as past medical history, medications, they may not be the best source. So you just have to use your critical thinking when you're looking at where your source is from. Secondary sources, we're collaborative in how we deal with patients. So we always want to talk to the CNAs. We want to talk to the other nurses that have been caring for this patient. We want to make sure that we have good communication with the providers, with respiratory, with physical therapy, all of those different disciplines. And we need to make sure that we have a good working relationship with the family and significant others, and we can get reliable information from them. And then the chart, definitely the chart is the first place that you want to go. When you go in and get ready to see your patient, you know, go early, look at your chart, get some information. You should have that information before you even walk into the patient's room. So an assessment includes collecting the data in a systematic and ongoing process. And the more you do assessments, the more you're going to be able to develop your own logical way of gathering information. Now, there are some tools on your Brightspace course site on doing assessments that will help to prompt you. So I encourage you to print those off and take them with you when you go in to do assessments on your patient. It really can help you make sure that your information is complete. So this is a copy of the paper copy of a care plan, and depending on your clinical faculty, they may have you use this to care plan, or they may have you use the SIM chart. Whichever model you use, you need to take something in there to write your notes down as you're gathering information about your particular patient. Now, where do you think you're going to get this information from that's on this first page? Very good. So you're going to go to the chart and you're going to look up this information. Again, when you fill this paper out, you don't ever want to put the patient's name on here, but you can use their initials, have some type of an identifier. So you do need to gather all of this data. You also need to look at the MAR, and you need to look at what medications that they're on. It is not uncommon, because we deal with a lot of elderly people in the hospital, to have patients that are on 12 to 15 medications every day. Do you need to write all those meds down? Yes. Right. There are going to be meds in there that they may not take on your shift. They may take them on night shift, but they can impact the patient's status. So you need to write those meds down. You need to know what those meds are. IV fluids, even if it's just normal saline to keep the vein open, which means it would go 20 to 30 milliliters per hour, that also is important. You know, patients can get overloaded with fluid. Now, current health problems. Where are we going to get this information from? Very good, Ginger. From the patient. Right. This is information that we're going to draw directly from the patient. You know, tell me what your pain is right now. What's a problem for you at this point in time? So yes, we need to get that information from the patient interview. You also need to look at diagnostics. So you need to look at lab results, and you need to look at radiology results. So if they've had a chest x-ray, if they've had a CT. Now, as you're starting to look at labs and gathering your data, your clinical faculty is going to direct you a little bit more. You know, do you need to include everything, or do you need to just include the abnormals? As you continue to learn to develop care plans, it eventually will get to where you're just putting the abnormals down on your lab sheets and your radiology sheets. Now let's talk about subjective and objective information, because that is important that you know the difference. So subjective information is what the patient says, or what the family says that's relevant to what you're looking at. So the patient may tell you they're having chest pain. The patient may say, I feel nauseated. If you can put it in quotes, that's great. If you can't remember exactly what they say, then don't put it in quotes. But you know, the patient stated they were burning up, or they were having abdominal pain, and it had started this morning. So the subjective data is what the patient perceives. The objective data is what we as nurses observe or measure. So an example would be a temperature of 104. We would observe that. If we were taking a dressing off of a wound, we would look and see there's bloody drainage on the dressing. So it's what we actually observe. Now in your textbook on page 46, chart 3.1, there are some examples, more examples of subjective data versus objective data, but that is very important. And as you're putting information down on your care plan, you need to put it under the subjective data, or you need to put it under the objective data. If your clinical faculty member has you use SimChart to do your care plans, then you're going to see this evidenced by. Evidenced by means the subjective data and the objective data, and you can just group it out. But the subjective data here is they're complaining of abdominal pain. Objective data is we looked on the MAR and they are taking hydrocodone. We looked at the lab and there's blood in the urine, and we looked at the radiology test and there's a stone noted in the bladder. So that's all objective data. Now we also need to validate the data. We want to make sure that the information that we're getting is correct. When do we validate data? Well, number one, when the subjective and objective data do not agree or make sense. So let's say that you're a parent and you go in to your son or daughter's room and it's time to go to school. And they say, oh, they don't feel well. So you go get the thermometer and put it in their mouth and you walk out of the room. You know, this is the pre-tympanic, pre-oral thermometers. And you guys have all seen this on television shows. And then the kid holds the thermometer up to the light. And so when the parent goes back in, the thermometer reads 105. And we know that we would need to validate that information. You can see the same thing with patients. If there's a difference in what you see and what patients are telling you, then you need to go back and validate that information. We also validate when the patient's statement continues to change. Now, you don't want to be doubtful of what patients are telling you, but again, sometimes it may be different at different times. So you need to validate that information. If data is far outside the normal range, I had a patient one night that I had given Phenergan to, which is for nausea, and she was elderly, and her breathing became very, very shallow. Well, when I put her on a pulse ox, she was showing a pulse ox of a normal range, but I could see just by watching her that she wasn't ventilating like she needed to. So I had to validate my information. Remember, we're not treating equipment, we're treating patients. So if your equipment says one thing, you see something different from your patient, you're going to have to go and double check that equipment. And factors are present that interfere with accurate measurement. So again, you're looking for those things that would say, you know what, this doesn't feel right. Something about this isn't clicking. I need more information. So let that guide you. So we are constantly assessing. The assessment helps to formulate the diagnosis, it helps in planning our goals and interventions, it helps in implementing, and it helps in evaluating. We are constantly assessing and reassessing our patient. Ferris Bueller. I don't understand Ferris Bueller, Charlotte. What do you mean? The movie? Okay. I probably said something and I just don't even remember what it was. Oh, yeah, right. He faked a stent. Exactly. So how is data used? So we collect that data. Again, we're with the patient more than any other discipline, but we use it to plan our care. We are collaborative with that information. We share that information with other disciplines to make sure that our patients get safe, competent, timely care. So assessment is key. I've worked with a lot of nurses that were not good at assessing. And again, the patients suffer. So an assessment skill, which is what you're focusing on this semester, is very, very important. Now, there are different types of assessment, and I think you guys learned a little about that when you met with Professor Arnapol, who can tell me what an initial assessment is. Baseline assessment, yes. So first time meeting a patient, yes. So an initial assessment is also called an admission assessment. That is an assessment that you do the first time that patient comes up on the floor. Can we delegate an initial or admission assessment? No, you cannot. Very good. So an RN has to do an initial or admission assessment. A student can't do an initial admission assessment. Now, your clinical faculty may have you do one on SimChart one time through this semester just so that you can see what it is, because it's very extensive. It takes a long time to do an initial assessment. And again, I encourage you when you're in the hospital to go in and look at the chart and see what their admission or initial assessment looks like. How about an ongoing assessment? What is that? Every interaction with the patient. Yes, Megan. So an ongoing assessment, an example of that would be a shift assessment. So when you go in at the beginning of the shift, you do a brief head to toe assessment on the patient. When you go in to take a patient their medications, you're still assessing, right? You're making sure that they can hold the pill, that they can swallow the pill, that they can drink the water. So ongoing assessment is with every contact that you have. A comprehensive assessment is everything. It includes emotional, spiritual, physical. It is everything. It's different from an initial or an admission assessment because you're looking beyond just the physical issues. You may be looking at their mental health. Are they going through something that's very difficult right now? Do they need some support? Do they need you to sit down and just kind of help guide them through that? And then a focused assessment. So a focused assessment, an example of that would be what we do in the emergency room. So I worked in the ER for about 5 years, and we would do focused assessments. Patients would come in with chest pain. We were very focused on assessing their chest pain. How long's it been going on? Rate your pain. Where is your pain? Does it radiate? Do you have any other symptoms? Now, we would also do a head to toe. We would listen to lungs, listen to bowel sounds, things like that, but we were very focused on looking at their chest pain. So it's looking at one body system and then following up on that. And special needs are areas that are very specific to your patient. So for example, the Braden skin assessment is a special needs assessment. So that's focused on looking at skin integrity and identifying patients that are at high risk. A nutritional assessment is a special needs assessment. So different types of assessments. So the first thing we do in assessing in the nursing process, after we've gathered our information from the chart, is we want to interview our patient. And there are a few guidelines that I just want to go over with you. Before you go in to do your interview in health history, you want to prepare yourself. So again, you've looked at the chart, you've got an idea of some questions that you're going to ask. You want to make sure that it's uninterrupted time. So it's not a good idea to go in right as the trays are being delivered or right before mealtime, because patients are probably not going to be very focused on you. They're going to be more focused on eating their food. So, you know, again, using your emotional intelligence and your common sense and making sure that you've got a good time frame to go in and talk to your patient. Making sure that you're organized. Nothing is worse for a nurse to go in and be unorganized and having to go in and out of the room and gather things. So again, you think through, what do I need? What am I going to need? What could I need? And make sure that you've got everything with you before you go into the room. And then take a deep breath and enter the room. Compose yourself. Now, I've posted an example of a bad interview on the Brightspace course site for week 4. So when you guys get some time, go back and look at that and see some things that are definitely not correct when you are doing a patient interview. You also want to call the patient by name. Now, this depends on what the patient wants to be called. So asking them, is it okay if I call you by your first name? Would you prefer that I call you by a title? What do you want me to, what are you comfortable with? So asking them, that's going to be important. Tell the patient what you're going to be doing. Okay, we're going to just do a brief questionnaire. I'm going to find out, what brings you in today. What are some things you're struggling with? Find out, what your past medical history is, your medications, and it's going to take us probably about 15 or 20 minutes. So establishing what you're going to do. And picking up on those nonverbal cues. So if you're talking to your patient and let's say you're unaware that maybe their boyfriend has just texted them and said that they're moving out or they're breaking up. And so they've got all this other stuff that they're dealing with. You've got to be sensitive to picking up on those cues with your patient and knowing when to continue, when to maybe give them a break, come back at another time. So just picking up on those cues is important. And don't forget cultural issues. So we've had patients that are from cultures where they are not comfortable with male nurses taking care of them. So if that seems to be an issue, you need to ask about that. Are they comfortable with that? Would they prefer a female nurse? So again, picking up on those cultural issues. Now, there are phases involved in assessment. And the first phase is the introduction phase. And this is where you gain or lose the patient's respect. This is a first impression. You want the patient to have a good first impression. And I want you to think about the demographic of where you're training to be a nurse. You are in East Tennessee. It is a very Appalachian culture. The majority of the patients you will work with are going to be elderly. Do you think an elderly person out of Union County is going to be comfortable with the young lady with the bright red hair coming in to take care of them? Maybe not. Right. Now, in a different environment, she may be just fine. But in the hospital, with the demographic that we have, that person is not going to warrant a lot of trust when the patient sees them. What about the person on the bottom? You think, again, a person from this area, an elderly person, may be more comfortable with that person? So again, we want to make a good first impression. We want to let patients know that yes, we do make good decisions and we're going to take good, safe care of them. Then the working phase. The working phase is when we're gathering the information. We need to stay focused during that phase. And it can be easy for patients to get off track and start talking about other things. And that's okay as long as it fits into our assessment data. For them to start talking about the neighbors, cousin's daughter has had cancer and they're just in a terrible way. You know, that's important, but we've got to stay focused on gathering the information that we're gathering. And then the termination phase, letting the patient know, you know, how long it's going to take us to do that. And okay, we're almost done. We've got just a few more questions and we'll be wrapping up. I'm sure most of you have been in those situations and you know how it feels when you don't have any information. We also can use directive interviewing skills or non-directive interviewing skills. And this is very important that you know the difference. Directive interviewing skills are using closed-ended questions. So you're getting specific information. You're getting the patient's age, you're getting their gender, you're getting their date of birth, you're getting what has brought them in today, you know, specific information. Non-directive interviewing skills are more open-ended questions and they yield more information. They allow the patient to feel like they're more in control. So again, when patients would come into me and I was working triage in the ER, I would say, what brings you in today? That's a very open-ended question. So patients can just tell you, you know, and from that, well, my stomach has been hurting. From that, you can do more directive or closed type questions. Where is it hurting? How long has it been hurting? What type of pain is it? So again, using both of those types of questions is going to be very important. Use active listening. Now, what does active listening look like? Nodding. Eye contact. Good. Attentive. Engaged. Repeating. Very good. So active listening, paying attention to nonverbal communication. So a patient may be telling you something, but they may be grimacing. They may be holding their stomach. They may be diaphoretic. They may look uncomfortable. So paying attention to those nonverbal cues. Avoiding healthcare jargon. And this is one of the tricks of being in nursing. You have to be able to communicate with a neurosurgeon, and then 5 minutes later, you have to be able to communicate with a layperson that has absolutely no medical knowledge whatsoever. So you've got to be able to flip back and forth. It is very important that you not use healthcare jargon with your patients. If you go in and say, okay, tell me how many times you voided today, or, you know, have you had a history of UTIs? So again, just bear in mind that we're breaking down that barrier so that we can give these patients the information they need. Curb your curiosity. It's very easy to go down a rabbit hole with patients sometimes. So again, you know, you're staying very focused in that working phase of the information that you're trying to get, and do not give advice to patients. So they've had liability malpractice issues where with neighbors, I'll never forget reading about this years ago, but a lady was a neighbor and she was a nurse, and her neighbor called her over and there was something, I can't remember, one of her kids were sick. And the nurse said, well, just give him some Tylenol or ibuprofen or whatever. And the child ended up being very ill, having to go to the hospital. The neighbor sued the nurse. So don't give advice. We are not physicians. So again, be very careful of that. And again, there's no voicing approval or disapproval. We're there in a professional aspect. We're not there to judge anyone for their lifestyle. This is just an example of branching questions and some tools that you might use. You can just look over that on your own. So when looking at your data, you need to make sure that your data is complete. You need to make sure it's accurate. You need to validate information that doesn't feel right or seem right. And you're going to start to draw conclusions. And we're going to talk more about that as we analyze the data and identify those patient problems. And then we're documenting. So as we document assessment data, Remember that we're documenting the facts. A chart is a legal document and it can be drawn into a court of law. So you need to make sure that you're not making any kind of a judgment call when you write things down. So for example, you're not going to chart the patient is sick. You're going to chart what you see, what you hear, what you feel, what you smell. So the patient vomited 35 milliliters of bile-colored liquid. You wouldn't chart the patient is in pain. You could chart the patient complains of pain in the lower left leg and it's scaled at a 3. So you just chart the facts. Okay, so here's an example of a patient, and this is a case study. And I want you to get your care plan out, your paper copy care plan, or if you printed it on your computer, whichever. And I want you to take a minute and I want you to break this information down into subjective or objective and write it on your care plan. And then when you finish with that, I want you to type in the chat box, which data is subjective? Good, guys. Very good. So it's what the patient states, which that the pain is at an 8, and what the family states, that the patient hasn't eaten anything in 12 hours. That is subjective data. What is the rest of the data? Objective. Yeah. We measure the vital signs. We can palpate and feel that the skin is cool and clammy. We can see that the patient is guarding their abdomen, that they're grimacing, and we can look at the chart and see that the patient had gallstones in 2017. Very good. Good. Now, what kind of information is this? Is this subjective or objective? It's objective, right? So from the chart, we've seen what the ultrasound showed. We can look at the chart and see that the provider has put the patient on a low-fat diet, and we can look at the MAR and see what medications the patient is on. So that is all objective diet. Madeline, if we ask the patient, what are you eating? And the patient says, I'm eating a low-fat diet, then yes, it would be. But diet, all this information has come from the chart. So your diet will always be in order from the provider. We can't just put the patient on a regular diet. That comes from the provider. So in the care plan, if that were relevant to your diagnosis or patient problem, it would be included in your objective information. Okay. So part of what you may do this week in clinical is you may start looking at information and putting it under subjective heading or the objective heading. Now let's look at this clicker check and see how you do. So the nurse is completing a head-to-toe assessment on her patient at the beginning of the shift for the hospital unit. This would be considered what type of an assessment? Oh, wait, I think that's a different question than what I've got. All right, you guys read this one and answer because I can't see part. Let me move the chat feature. Oh yeah, that's better. Oh, okay. I've lost my thing. Okay. There I am. Darn it. Hang on a minute, guys. I'm trying to get my PowerPoint up. I can't seem to see it. There it is. Okay. And let me go back to my chat feature. Here we are. Okay, so which action by the nurse might be a barrier to obtaining complete and reliable information from an interview with the client? Noting that the client's body language indicates that he or she is fatigued, maintaining eye contact with the client if it is not culturally inappropriate to do so. I think that's a very confusing way to say something, but it's a good example of an answer. Carefully guiding the conversation so that important topics are discussed, or asking the client directly, why are you not taking your insulin? So the answer is D, because that is a barrier. You never start by asking a patient why. Why is seen as accusatory. Now I'm having trouble with my chat feature, so it may take me a minute. Now here's the other question I was going to show you. So you guys look at that and see which one you think. See if I can get my chat feature up. Nope. So the nurse is completing a head-to-toe assessment on her client at the beginning of the shift for the hospital unit. This would be considered an ongoing assessment. So it would be C. Remember, your focused assessment has to deal with the specific issue that's going on. Your initial assessment is the same as your admission assessment. And your special needs assessment would be something very specific like a Braden skin assessment or a nutritional assessment. All right, so let's move on to the next step in nursing process, and that is diagnosing, the D. So nursing diagnosis. So what is diagnosing? Diagnosing is when we analyze the data and we come up with a patient problem. Now again, remember, the patient needs to be part of this. So they need to buy into what their problem is as well. But it gives meaning to the data that you collected, and it helps in organizing your data. Now, let me say this about your textbook. I think your textbook does a very confusing job in this chapter. So you can look at the textbook, but be very careful of their wording. If I were you, I would just focus on the PowerPoint and what I'm going to say here, because I've worked at trying to make this not as confusing as how they've got it in that textbook. It is very important that you know the difference in a medical diagnosis and a nursing diagnosis. So a medical diagnosis describes a disease, illness, or injury. An example of a medical diagnosis would be cholecystitis, which is a gallbladder disease. Pneumonia is an example of a medical diagnosis. Congestive heart failure is an example of a medical diagnosis. A nursing diagnosis is a human response to a health condition that nurses can impact. It is a human response to a health condition that nurses can impact. And it's, again, very important that you know the difference. We are not physicians. We do not work from a medical framework. We work from a nursing framework. So an example of a nursing diagnosis may be fluid volume deficit related to poor fluid intake, or decreased activity related to pain in lower legs. So we're focusing on that human response. You should not have a medical diagnosis anywhere in your nursing diagnosis. A nursing diagnosis can be managed independently or dependently. If we manage nursing diagnosis dependently, that means that we are working in a collaborative way. So we do not independently treat a medical diagnosis. So for example, we can't prescribe oxygen. We can't give a patient Tylenol in the hospital. We have to have an order for that. So we operate in collaboration with all of the different disciplines that are in there. Now, we manage therapies for medical conditions. So we do give Tylenol with the order of a physician. We do give oxygen. We do put in IVs and catheters, but we have to have the order of a provider. It is actually illegal for us to treat a medical problem or to diagnose a medical problem. That is not what we do as nurses. We treat and diagnose human response. Does that make sense? Hopefully it'll kind of pan out as we work through this, but that is very important that you know that. Nurses can lose their license for diagnosing or treating medical conditions. Now, how do we come up with a nursing diagnosis? Well, there is a body of knowledge known as NANDA, and NANDA is a group of all the different nursing diagnoses that we can use on patients. And again, I don't want you guys to pull this out of your head. Okay, you have lots of resources that can help you with that. One is that Sparks and Taylor book that is free on StatRef, and I'm going to show you guys how to access that in just a few minutes. Also, SimChart. SimChart has a list of nursing diagnoses by medical diagnosis. So you know what the medical diagnosis is. You go in and it gives you a list of nursing diagnoses that you can pull from. So this is not terminology that you just have to come up with. It's already built and it's out there. So when I say that nursing diagnoses are human responses to health problems, what are health problems? Well, a definition of a health problem is any condition that requires an intervention in order to prevent it, to resolve it, or to treat it. and we decide how we're going to treat those. So we may treat them independently, meaning we don't need a physician's order. So we can put a patient on intake and output. We don't need a physician's order for that. We can turn a patient every 2 hours. As long as there's not a contraindication, we don't need a physician's order to do that. We don't need a physician's order to teach patients about their ostomy or to teach them about their medications. So there are lots of interventions that we can do without a physician's order. Part of what you're going to be learning in the next 2 years is what those are. Or we can treat collaboratively. So if you're giving a medication, you're treating collaboratively. If you're starting an IV, if you've put a patient on oxygen, then you are treating collaboratively, meaning that you have to have an order in order to do those types of treatments. I don't want you to get caught up in this slide. Just know that collaborative problems, we're working with the providers with other disciplines. Now, there are types of nursing diagnoses, and I only want you to focus on the first two. I want you to focus on actual and risk for. Your textbook goes into 3 or 4 different types of nursing diagnoses, but again, in order to make this less confusing, we're just going to focus on these first two. So an actual diagnosis means that it's happening right then, okay? It's occurring. Every care plan you do on a patient should have at least one actual diagnosis. So I've seen students' care plans where they have all risk for or potential for and no actual. There's a reason the patient's in the hospital. So you need to have at least one actual diagnosis. And then there are risk for nursing diagnoses. These are potential. So if a patient has a Foley catheter inserted in their bladder, then they're at risk for developing an infection. If a patient has been put on bed rest, they are at risk for developing a blood clot or for developing fluid in their lungs or ineffective airway exchange. So we have actual and we have risk for. And we're not going to really go into that slide, so let's don't really worry about that one. Let's talk about analyzing our data. So analyzing our data means that we're identifying significant information. Remember, we talked about on our other patient, if the patient had their tonsils out when they were 6, or they were blonde, or they were female, remember their blood pressure was very high. That wasn't significant, but the fact that they had had surgery, the fact that they were having pain at a level 6, that was significant. So part of what you're going to do after you gather your subjective and objective data is you're going to look and see what's significant. And you can do that in a variety of ways. Some students will actually draw circles around information that's significant. And then you start to cluster cues. So things that are going to be relevant to what you think may be a problem with your patient. So if you think maybe a problem is they have a fluid volume deficit, they're not taking in enough fluid, then you're going to start to cluster information around them not taking in fluids, being nauseous, maybe being immobile, being confused and not being able to recognize when they're thirsty and not taking in enough liquid. So you're going to start to cluster those cues. And then you're going to start to make inferences or judgments. Okay, so I see all this information that's coming up that shows me that maybe there's a fluid volume deficit, and I'm going to say there's a fluid volume deficit related to, it may be immobility. They can't get out of the bed. The staff isn't responding to their call light. Maybe it's confusion. They don't know that they're thirsty, so we're going to have to push fluid. So you start to make a call about what's going on with your patient. And then you start to look at etiologies or causes. That's just causes. So it's related to. What is the fluid volume deficit related to? Is it related to their confusion? Is it related to an irritating substance? Maybe they're nauseated from the pain medication. So what is the problem caused from? And again, we're pulling our patient back in and we're going to verify that problem with the patient. So, just help me to understand, this is a real problem for you, that you feel like you're going to fall, you can't get out of bed, the CNAs aren't responding to your call eyes. So you're verifying with them what they feel like an issue is. Now, one thing you'll see in the Sparks and Taylor book are something known as defining characteristics. And defining characteristics, again, is just data that supports the patient problem. So if you look at that Sparks and Taylor book and you've identified a patient problem or a nursing diagnosis, under it you're going to see a whole list of defining characteristics. If you look at that nursing diagnosis and your patient doesn't have any of those defining characteristics, then that nursing diagnosis may not be appropriate for your patient. So let's look at this patient. So we've got a patient who has had a 10-pound weight loss. They state that they don't have a good appetite. They feel weak. They feel tired after walking. And they're short of breath. They're having trouble breathing when they start to exert themselves. So we have clustered all of the significant information. We've compared it with standards for what's normal, what is abnormal, and we see that normally a patient shouldn't lose 10 pounds unless they're trying to. Normally they shouldn't have a poor appetite, and normally they should be able to walk a reasonable distance without feeling tired or getting short of breath. So from that data, we're able to analyze it and make an inference that there's a problem with their nutritional intake and there's a problem with their activity level. So you could say a decreased activity tolerance or activity intolerance related to, and we would figure out what's causing it. Or we could say decreased nutritional intake, less than body requirements related to, and we would figure out what's causing that. So those are examples of taking the assessment data, analyzing it, and forming a patient problem. So look at this slide. Do you see the medical diagnosis is a ruptured appendix or appendicitis? Okay, that's a medical problem. That's not a nursing problem. But from that information, we have a patient that's not able to get up and move around because they have a painful incision. So we word it impaired physical mobility related to painful incision. All right, let's look at this one, and then we're going to stop and see what questions that we have. You guys read this little scenario. Okay, so your patient has diabetes mellitus type 2. What type of problem is that? Is that a medical problem? Is that a nursing problem? Or is that a collaborative problem? And I can't see the chat feature right now, so I'll just tell you that that is a medical diagnosis. Type 2 diabetes mellitus is a medical diagnosis. Now, based on this scenario, what is the nursing diagnosis? So the nursing diagnosis is impaired skin integrity. That is a human response to a health condition. And what is the impaired skin integrity caused from? So the decreased circulation and mobility is the cause. Good. All right, well, we are going to stop there. And I'm going to stop my screen share. And because I can't see my chat feature. And we'll see what questions you guys have. And let's see. What questions do you guys have about assessment and diagnosis? Or is those two pieces of writing a care plan? Do we have online class for fundamentals and then show up at 11:45 for the exam? Yes, that's correct, Chloe. We have class from 8:30 to 10:30. We'll be finishing up process. You're welcome. You guys feel like you've got a pretty good handle of how to assess, how to cluster the information? Yes, same room as last week. You won't change your room for pharm exams. Feel like you've got a pretty good idea on what's subjective and objective? How to analyze the data? How to pick out a patient problem? If you get to the eval of nursing and your plan hasn't worked, do you start from the beginning or just go back and tweak your interventions? So if you get to the evaluation, you evaluate the goal. If the goal has not been met or partially met, then you go back and tweak your interventions and see what you need to do in order for the patient to meet the goal. Medical diagnosis versus nursing diagnosis, COPD versus decreased respirations due to, yeah. So COPD is your medical diagnosis. Your human response may be ineffective airway exchange related to increased mucus in the lungs, related to permanent damage to the alveoli. It's something very specific, but it is not the medical diagnosis repeated. So guarding and grimacing are objective rather than subjective, correct, because you can see it. If you can see it and measure it, it's considered objective. Now the patient may tell you that they're hurting, and that would be subjective. In the care plan book, do you look up the medical diagnosis and then the suggested care plan with it? That's a good question, Angela. And my recommendation at this stage is yes. If you look up the medical diagnosis, it's going to give you a list of nursing diagnosis. And then you can look at those and go back to your nursing diagnosis. And under the nursing diagnosis, it will list defining characteristics. So if you look at those defining characteristics and your patient doesn't have any of them, then you know that's not going to be appropriate for your patient, and you may need to go to another nursing diagnosis. Yes, so Megan, there's an extra letter in ADPI, and there's some books and documents that will use AADPI. They'll say assessment, analyze, diagnose. But the one that we're using is just the ADPI. When doing an assessment at the hospital, do you write the chart as you assess, or do you later? It's so much to pay attention to. That's true. Anna, the PowerPoint, which we'll get into tomorrow about documenting, says that you chart as soon as possible, and that is true. I personally will make notes on a piece of paper just because I'm more comfortable doing that, and then I'll go and I'll do my charting. I'm a quiet worker, so I don't, patients and families talking to me, I'm not going to be able to chart as effectively. So, you know, it's a preference, but as soon as possible, definitely. You mentioned, oh, hang on, let's see. You mentioned that we don't mention, oh, I can't see your question. Whoever just did that question, if you would. write it again, please. Oh, here it is. That we don't mention about the medical diagnosis in the care plan. So even if they're talking about something in the nursing diagnosis that regards the medical diagnosis, are we still not allowed to even only reference existing? So what I normally see, Jennifer, is students will write ineffective airway exchange related to COPD. That is a medical diagnosis. It doesn't belong in the nursing diagnosis. So it has to be the cause, you know, so you have to know a little bit about COPD. You know, what's causing the ineffective airway exchange? Is it that there's, again, damage to the alveoli? Does the patient smoke all the time? Do they have scar tissue in their lungs? So it's going back a little bit further, but not putting it under that medical framework. We want to think as nurses, not physicians. Does that make sense? Kinda? I can see you, Jennifer. I can't see everybody, but I can see you. And it's tricky. So again, use your book. So your care planning book, your SIM chart is going to help you when you go back and start to try to develop these diagnoses. You don't need to try to do this on your own. You know, use the resources that you have. They're really going to help a lot in giving you the words to say. Let's see. So if we think the patient has an underlying condition that's not diagnosed, how would we go about getting them the help that they need? Just charting the suspicion. So you chart your assessment data. And Alexandra, if you need to, you know, contact the physician, then you do that. For instance, if we want dietary to come in, or respiratory or physical therapy, you have to have an order for that. That's all about reimbursement. So your primary source is going to be to go back to your provider. Anna, so even if you know it's a medical diagnosis, you should never mention the COPD word, right? Yeah, you want to stay away from the medical diagnosis. You want to think like a nurse. So nursing diagnosis is a human response to a health condition, not a medical diagnosis, a health condition. Okay, other questions? I want to leave a few minutes to go to StatRef. Oh, good, we're in a fire drill. All right, well, y'all, you guys are home, so I'm just going to exit it. So it's fine. If you see flames behind me, let me know. I can't see. I don't care. I worked in the ER. It doesn't matter to me. I get out anything. All right. Do we need to bring a calculator? No. Heather, you will have a calculator on ExamSoft. So you have that tools feature on the right. I'll have to probably work really quick because I bet security is going to come down here and check, make sure I'm out of the office. I'll just pretend I don't hear him. Okay, I'm going to go back and pull up StatRef on the course site because I want you guys to see what this looks like. Let me get it pulled up first, and then I'll share my screen with you. Share screen. Okay. So if you go into the course site, Andrew, can you see my screen? Because I can see you. I can only see a few of you. Okay. So if you go into the course site on the right, you'll see a bunch of what's called widgets. And one of them is StatRef. If you click into StatRef, you'll see a list. And this is available to everyone that's a Pella Sippy student. So these are different types. There's a Davis Drug Guide right there. There's a different fundamentals. Don't look at that one. Look at the one you've got. But Nursing Diagnosis Reference Manual, Sparks and Taylor. So you guys all have access to that. If you go down here to selected nursing diagnosis, you see there's a list of medical diagnosis. So they're all alphabetical. So you could go down here and look at any of them. So let's just look at acute pancreatitis. So if our patient has a medical diagnosis of acute pancreatitis, these are all possible nursing diagnoses that you could use with this patient. So this, let's say we've got acute pain. So we would click back up here on adult health. And you see that there's a list of nursing diagnoses. Now, they're not truly alphabetical. I don't know how they've designed this. It always takes me a minute. But if you look here, there's one for acute pain. And if you click on acute pain, it says related to biologic injury agent. So the patient may have gallbladder disease, they may have an infection, but we can put it under biologic injury agent as the cause. Different books will word it different ways. So it doesn't matter how it's worded as long as it describes what the actual cause is. And then you can go under and see defining characteristics. So if your patient meets, not all, a few of these defining characteristics, then it may be appropriate. They'll list goals. You would only have one goal per nursing diagnosis, and we're going to talk more about that tomorrow. And certainly these goals would need to be individualized for your patient. So saying that the patient will rate the pain on a scale of 1 to 10 is not specific enough. So you would have to make that more specific. And then here are a list of interventions with rationale. So look at the first intervention, assess, because we always assess first as nurses. So again, you're not pulling this out of your head, you're pulling this out of a bank of information. So that is one source. Now, I want to show you this other one if I'm still in here. Andrew, can you see SimChart? Okay. Oh, the fire drill's over. I didn't burn up, I'm so glad. So if you click into SimChart and your faculty, clinical faculty, have you use SimChart for your care plans, it's all drop down. It's very easy. Again, it's based on medical diagnosis. So you've got a list of medical diagnosis here. You click one, and then it will give you a list of potential nursing diagnoses. So if we choose acute pain, then we will put why, what it's related to, and see here's your evidenced by. So this is where all your data is going to go that would support this nursing diagnosis of acute pain. Your expected outcome, one goal per nursing diagnosis, and then there are a list of interventions that you can choose from. Now, those of us who teach don't really love this drop-down box because we think it kind of prevents students from really using their brain a lot of times, but it is very convenient, and it certainly gives you a reference point. Even if your faculty member doesn't have you use SimChart for care planning, you still could go back and use it to help develop your care plan and put it on that paper copy. All right, I'm going to stop sharing here. What questions do you have about that? So the main thing is that we're trying to connect the human response to a physiological process effect of the medical diagnosis for the evidence by. Yes, Christopher, that's correct. Yeah. So it's, again, a human response to a health problem, not a medical problem, a health problem. So what's going on with the patient that's caused them to not have the activity level, to have a knowledge deficit. Maybe it's a knowledge deficit related to a new medication. So, and again, you guys don't be too hard on yourselves. You're just starting this, okay? You're just starting. So this will come. This will build as you go through the program. That was a good question. Other questions? All right. Well, you guys did a great job today. I think you've got a good start. Again, I encourage you to go into SimChart, to go into StatRef and look at that. And then we will meet back here in the morning at 8:30. I'll answer these questions. If you want to hang out and see what the answers are, you're fine. If not, you guys are free to go. Hope you have a good rest of the day. So Cameo, mixed information on what to put or not put for name, weight, age. We're advised our initials only, absolutely no identifying factors. Correct, no identifying factors, Cameo. You can just put their initials.